Floor.
Is it working? Okay. Good afternoon, everybody. Allow me to personally welcome Dr. Brad. She was with us when we established the society 30 years ago, and it's very glad to know that she's still with us now. Just that I didn't realize that after 30 years, we'll come together and argue with each other. So, but maybe you can just call it friendly fire. Right. So this is the opinion paper. And of course, I'd like to acknowledge my friend, Santiago. Santiago we were together in the board of directors of the International Medical Society some 25 years ago. And that was when the WHI came out. And we were smacked in the face with the WHI. And that's why we know a lot about WHI that most other people. Right? Anyway, this is an opinion paper, and these are statements are mine, but they are as much as possible reference. All right, the question is, does MHT have a role in the primary prevention of coronary heart disease? I think that's not the question. I think the question that should be asked is this, and I think it's a real question. Is MHT indicated for the primary prevention of CHD? MHT may have a role, may be beneficial in the prevention of coronary disease, but is that enough to make it an indication or to make it indicated for the prevention of coronary disease? Because indication means you look at the benefits and the risks. If there are benefits, but if it has risks, then you will not use it for the prevention of coronary disease. So the question we're supposed to answer is, does MHT have a role in primary prevention of coronary disease? And the answer, of course, is, my answer, right, is yes. But it depends. As many answers are. And it depends on what? It depends on the testing hypothesis. Unless you accept the testing hypothesis, there will be no argument. The role of MHT, and when we say MHT, we actually mean not estrogen, progesterone, we mean estrogen. Because progesterone was there simply to prevent endometrial hyperplasia. So the role of estrogen in the prevention of coronary heart disease depends on the time the MHT was initiated. This is also known as the early initiation concept or helping the hypothesis. This is not a new hypothesis. This is very old, older than WHI. WHI is 20 years old, right? And the reason why we say WHI most of the time is because this is when the world became topsy-turvy in the medical world anyway. And the world before WHI was completely different from the world we have now. But this was way before WHI. The concept of early intervention versus late intervention. And the pioneer for this is Thomas Carlson. Anyway, what is the timing hypothesis? This is one of the latest papers looked at the timing hypothesis. This is by Howard Hodges. Howard Hodges was mentioned earlier by Susan Cheney. He's not a gynecologist, he's a cardiologist. He's one of the primary researchers in cardiology in California. And he said that menopausal hormone therapy and reduction of all-cause mortality and cardiovascular disease. Now, we're going to talk about MHT and cardiovascular disease. What's the role of mortality? Well, you always have to place mortality there, because in the end, that's the most important thing. Whether you live or die, it's not cardiovascular disease, it's whether you survive for another day. So they are almost always together. And it says about time and timing. So what does time hypothesis say? It says that estrogen is beneficial on the healthy epithelium at younger ages, meaning a woman in early menopause. And when we say early menopause, a woman who is 10 years below 60 years of age. Menopause is a biological constant, more or less it's about 50. So 10 years before 60 years of age, or 10 years, less than 10 years from the final menstrual period. That is what we arbitrarily call early menopause. Late menopause is woman is more than 60 years old or more than 10 years since last menstrual period. So it is beneficial on healthy epithelium at younger ages. It has adverse effects on established clots, typically at older ages. Now, this is the natural progression. This is a schema of a natural progression of atherosclerosis. This starts actually when you're a teenager and goes on throughout life. What it means is something like this. The concept of cardiovascular disease as a head or head-neck condition has been replaced with the idea that cardiovascular disease develops over time. And all of us, men, women, and teenagers, are some way within this continuum. So let's go back to this. So you have 30-45, pathology of the vessel, and then going through to 65. And you can see by 50 to 65, there already development of a plaque, right? And a bigger plaque 10 years later. Now, what is the effect of estrogen on the natural progression of atherosclerosis? Between age 35 and 45, estrogen is beneficial. There is less LDL oxidation. I'm not going to read this, I'm a cardiologist here to interpret. Just take it as an act of faith that between 35 and 45, estrogen is beneficial. Alright, so we don't have to deal with something that I'm not an expert on. Now, between age 55 to 65, unfortunately, there is already loss of the beneficial effects of estrogen on the vessels. Why? Because the vessels are aging or may have been diseased. And then at age 65, if you have a plaque, by this time, estrogen will make the plaque bigger. So estrogen is good when you are younger, early menopause. It's worse after the late menopause. Right. So, is there evidence for coronary disease benefits of MHT when initially occurred? Let's look at just about 3 studies. We have only 20 minutes to talk. This is 2006. This is the saltpeter meta-analysis. This is the first one that came out after WHI. WHI was 2002, right? And this is a meta-analysis of 23 randomized controlled trials, 181,000 women. Women years of follow-up. And I draw a forest plot using my computer. This is not vertical, this is horizontal. But it's basically the same. And I want you to look at the numbers. And I want you to read it for me. This is as a word. But anyway, the first line is all ages, right? When you see the axis, you can see 1. 1 is the reference. These are non-users of CEMBA, right? Or rather of estrogen plus progestin. And the value for users is 0.99. So it's less than 1% from 1. But in 95% confidence interval, you see that line, that crosses 1. Statistically, that renders that figure not significant. Which means, therefore, that at all ages, when you use CEMBA, and you look at the risk of coronary disease, no effect. It does not really increase. It does not really decrease. The conclusion is no effect. So there is a 1% non-significant decrease in the risk of coronary disease in all ages. Now, if you look at women more than 60 years of age or 10 years since menopause, the relative risk is 1.03, that's 3% increase. But the 95% CI crossed 1, so that is 3% statistically insignificant increase in the risk of coronary disease. If you look at the third column, you will see 0.68. This is for women less than 60 years of age or less than 10 years since menopause. These are the women in early menopause. And the value is 0.68. So that means how much from one? How much? 32% is statistically significant because you see that the 95% confidence interval, both maximum and minimal point estimates are below 1. So you say that there is 38% statistically significant decrease in the risk of coronary disease when MHT is taken by women who are less than 60 years of age or less than 10 years since menopause. That's 2007. Now, there are two studies here that I'm going to present to you, both by Howard Hodges and Wendy Mack. This was in 2013, and the reason why I present these studies because it gives us comparison of therapeutic efficacy and comparative risks with other non-hormonal preparations that we use for the prevention of coronary heart disease. Should I have a glass of water, please? Right. And this is the result. I'm going to go through it step by step. This is women aged less than 60 years. We're not talking about women more than 60 years. We're talking about women between 50 to 60. Right? Less than 60 years of age or less than 10 years since menopause. And we're looking here at the risks of coronary heart disease. Thank you very much. And we will look at two studies, actually one meta-analysis and one Cochrane review. Meta-analysis is by Saltpeter, 2006, right? And you can see, and we have shown this earlier, 68, that's a 32% reduction, statistically significant in the risk of coronary disease. Now, the Boardman study is the Cochrane review of 2015, when they isolated those women who were less than 60 years of age. There was a 48% statistically significant reduction in the risk of coronary disease. Right? Now, this is for hormone therapy. What about lipid-lowering therapies? 3 studies, or 3 randomized controlled studies, all of them 0.89, 0.85, 0.79, reduction in the risks of coronary disease with statins. And all of them were statistically
significant.
Not significant. Why? Because 95% confidence crossed 1. Now, what about aspirin? Again, 3 studies. Burger, Ricker, and Gala. No change. No difference. No effect. Because 95% confidence interval crossed 1. And that is how it should be interpreted. I have a last one, and that is an ACE inhibitor. Just one study, again, showing no change. So all of this, except HRT, reduce the risk of coronary disease in women who were less than 60 years of age or within 10 years since menopause. But as I said earlier, what is much more important is not coronary disease, although that's the topic of our discussion. It is mortality. So let's look at the risk of all-cause mortality. Women 60 years of age, less than 60 years of age, or less than 8 since menopause. Hormone therapy, we now have two meta-analyses and one top-grade review, so better, and you can see that in all these three publications, there was significant reduction in the risk of all-cause mortality in women who are on MHT. Now, what about lipid-lowering therapy? Again, two studies showed no effect. Aspirin, two studies showed no effect. And ACE inhibitors showed no effect. The reason why I'm saying this is because many times we tell women, or not we, because I never said it. I heard doctors say, cardiologists say, forget MHT. Look at the useful things that we do or we give to prevent coronary disease because they are proven. I will say this now, that they were proven for men, not for women. Right. Then I have 2019. This is a systematic review meta-regression analysis to examine the timing hypothesis. And what they did here was analyze 51 randomized controlled trials, right? And then I developed a graph, right? And just look at first all-cause mortality in the middle. And we divided these patients according to their mean age. There were 8 RCTs. If you look at the target mortality, first column there were 8 RCTs. The mean age of the women was 54. There were 17 studies, the mean age was 63, right? And there were 9 RCTs, the mean age was 67, right? Now, you can see that as the mean age goes up, there is, at 54 mean age, 8 RCTs, there was a 39% reduction in the risk of cardiac mortality. But this appears as the woman gets older. Now, if you look at all-cause mortality, it's the same. Reduction when the mean age is 54, there's no change anymore when the mean age was 62 and 69 and 66. So all proving that if you start MHT early, it may be beneficial or it could be beneficial. If you start it late, it will not be beneficial. There's a non effect or maybe even a detrimental effect. Now, this is the last topic I'm going to discuss. Problem is the timing hypothesis accepted by all people, by all concerned? And the answer, of course, is no. That's why we have a debate, right? But I'm going to show you 3 studies. Not 3 studies, this is WHI. I'm going to follow WHI across the last 20 years and see what the WHI is saying about the timing hypothesis, right? 2002, that was the first paper that came out. And the conclusion is C plus MPA should not be initiated or continued for primary disease prevention because, and I would like, and I put it in italics so I will not forget it, substantial risk for CDD and breast cancer. That was the first paper. They were concerned, there were some benefits, but they were concerned about substantial CDD and breast cancer risks regardless of age, and therefore, there's no timing hypothesis there. 2007, women initially aged 80 closer to menopause tended to have reduced risk. But their conclusion is that this trend test did not meet our criteria for statistical significance. The only conclusion I can make of this is that WHI has a different science for statistics because that's your own criteria. But at least they did not recognize timing hypothesis. 2008, legal support for the hypothesis. Okay? 2014, current evidence does not support timing hypothesis. But there's a difference here because of the increased risk of stroke and DTE in all groups. In 2002, they were concerned about breast cancer and increased cardiovascular disease. In 2014, they were not. They were concerned about stroke and DTE. Now, why did it change? When the risk different now, 15 years later, now, I will give you the answer, and I will give it to you now in the open forum. Why they changed the risk from breast cancer and cardiovascular disease earlier, now they're no longer concerned about that. They're not concerned about DTE and DET and PE. Now why? I'll give you the secret later, if you will remember to ask it to the open forum. Now, 2017, this is now Manson's time. It has become clear that the age of menopause or menopause onset likely influence cardiovascular disease risk. And last of all, 2020, hallelujah, timing of HT initiation influences coronary risk. At last, WHO admitted it, and the timing hypothesis is correct. More favorable effects in women who are less than 60 years old or within 10 years since last period. Another paper. This is a scientific statement from the American Heart Association, published 2020. They called the menopause transition a period of accelerated cardiovascular risk. And the reasons are because during the menopausal transition, there are vasomotor symptoms, sleep disturbances, central adiposity, right? Paracardial fat volumes are higher, increase in lipids, increased risk of metabolic syndrome, vascular remodeling, all of this tending to increase the risk of developing cardiovascular disease post-menopausal. They come during the menopausal transition, and there are risk factors for cardiovascular disease a little later in the menopause. And their conclusion is MHT, that's menopause transition, is a critical window for implementing early intervention strategies to reduce cardiovascular risk. That's the answer for you from the American Heart Association. But the US PSTF, hormone therapy for primary prevention of coronary disease by the US Preventive Services Task Force. This is the latest one, November. This is not the first one from the US PSTF. This is the fifth one. This is the fifth iteration. They had one in 2002, 2009, 2015, and this is 2020. And the conclusion is almost always the same. And what's the conclusion? It's not only conclusion. They put a black box warning on the menopausal hormone therapy. See, summary recommendation against use of combined so dry. The primary prevention of chronic disease in post-menopausal persons, against use of estrogen alone, the primary prevention of chronic conditions in post-menopausal women who have hysterectomy. And they put it in a black box warning. Why? Because up to this time, the USPSTF has not believed in the timing hypothesis. The current evidence does not confirm the beneficial effects of timing of initiation. So, does MHT have a role? Primary prevention of CHD? Yes, it does. And it depends on whether you believe in the timing hypothesis or not. The next question Is MHT indicated for primary prevention of CHD? We will answer that in the open forum. Thank you very much.
Thank you, Dr. Delfin Tan, for such a good presentation. So we now call on our cardiologist, Dr. Cabral, to give her rebuttal, to give her presentation, not rebuttal yet. Dr. Tan, maybe we can ask you to stay on the sofa.
Thank you, and good afternoon, distinguished guests, friends, and colleagues. I am privileged to join you at the 2023 Philippine Society of Climacteric Medicine Annual Convention and heartily congratulate the Society on its 30th anniversary. It is my honor to participate in this debate with the eminent Dr. Delfin Tan on the issue of the role of menopausal hormonal therapy, or MHT, in the prevention of coronary heart disease, or CHD. And I thank the organizers of the annual convention for the invitation to be with you today. Coronary disease is a leading cause of mortality among women nearly everywhere in the world, including the Philippines, and its risk increases post-menopause. For many years, MHT was believed to not only alleviate menopausal symptoms, but also offer cardiovascular benefits. A turning point in the perception of MHT's role in cardiovascular health came with the Women's Health Initiative study initiated in the 1990s. Contrary to expectations, the WHO study found that estrogen plus progestin hormone therapy was associated with an increased risk of coronary heart disease, stroke, venous thromboembolism. This revelation had a profound impact on clinical practice, as many women and healthcare providers became more cautious about using MHT, and a rapid and long-lasting decline in the use of MHT occurred. Since then, however, new studies and sub-analysis of data from previous studies have nuanced our thinking about the use of MHT in women of different age groups at different stages of menopause and at various risks of CHD. Our hope is that this debate may further inform your medical decision-making and your clinical practice on the subject of MHT. As stated in the program, the topic of our debate is, does MHT have a role in the primary prevention of CHD? And just so we are clear, and I actually had this approved by the organizers, we shall be debating specifically whether MHT has a role in healthy menopausal women for the sole indication of the primary prevention of coronary heart disease. I shall take the current position that there is no role for MHT in the primary prevention of coronary heart disease in healthy menopausal women with no other indication for MHT. I say this is my position at the moment because, like Dr. Tan has been saying, and because we all know and do, when the evidence changes, our practice changes. Beginning in the late 1980s, there was a shift from prescribing short-term estrogen therapy for menopausal women for symptoms to prescribing it long-term for prevention of CHD. This prevention strategy was based on more than 30 observational studies, almost all of which demonstrated a striking protective effect of estrogen on the heart. However, the WHI revealed that MHT was not quite effective for the primary prevention of CHD. The WHI trial, a set of clinical trials in healthy postmenopausal women 50 to 79 years. One of the trials was discontinued 3 years early due to a clear increased risk of CHD, stroke, and venous thromboembolism, as well as breast cancer over a follow-up period of 5.2 years. The WHI unopposed estrogen versus placebo trial in women who had undergone hysterectomy was also discontinued early due to an increased risk of stroke and a finding that suggested that there was no overall health benefit derived from the use of estrogen compared to placebo. However, there was a suggestion of a protective effect in younger women and that the increased risk may be confined to older women. Another study, the KIPS, found that there was no acceleration of atherosclerosis as detected by carotid intima media thickness and coronary artery calcium score. KIPS suggested that estrogen given to recently menopausal women may not harm the women through accelerated atherosclerosis, but it did not go as far as to suggest that it does any good by reducing the rate of atherosclerosis. Then, interestingly, the Davis Osteoporosis Prevention Study, or DOPS, provided evidence for a beneficial effect of MHT on CAD risk reduction when started early in menopause. The DOPS is an open-label, randomized, controlled trial to investigate the long-term effect of hormone replacement therapy on osteoporosis. Cardiovascular outcomes were also investigated in recent menopausal women aged 45 to 58. Half received MHT and half did not. Intervention was stopped after almost 10 years owing to adverse reports from trials such as the WHI, but participants were followed for outcomes for another 6 years. At 16 years, MHT had reduced the risk for cardiovascular endpoints compared with no treatment. It was concluded that women receiving hormone replacement therapy early after menopause had a reduced risk of mortality, heart failure, myocardial infarction, and an apparent increase in the risk of cancer, VTE, or stroke. The DOPS bolstered the position of investigators and clinicians who subscribe to the timing hypothesis. The timing hypothesis was built on the premise that there was a duality of estrogen effects on the natural progression of atherosclerosis. It was proposed that estrogen exerts early beneficial effects on the healthy endothelium but adverse effects on established plaques. It has been suggested that hormone therapy closer to the time of menopause may have more beneficial or less deleterious effects on CHD than MHT initiated later. And this proposal is what is termed as the timing hypothesis. This hypothesis seems to be supported by observations from the WHI. The WHI population was an older population when compared to most observational studies. The older age at the time of MHT initiation would be expected to be associated with more subclinical atherosclerosis, with lesions that may be susceptible to the prothrombotic and pro-inflammatory effects of estrogen. In contrast, starting MHT soon after menopause may not cause harm or may possibly be beneficial because of advanced unstable atherosclerotic plaques have not yet formed. In a combined analysis of the two WHI trials, women who were younger and started MHT closer to menopause appeared to have a lower risk of CHD compared with women further from menopause. Unfortunately, many of these findings did not reach statistical significance. In the elite, postmenopausal women stratified according to time since menopause received oral estradiol or placebo for a median of 5 years. Progression of subclinical atherosclerosis measured by carotid intima media thickness was slower than placebo in the early intervention group, while rates of progression were similar to placebo in the late intervention group. Estradiol had no effect on CT coronary artery calcium in either late or early intervention. The DOPS is often quoted as the study that supports the timing hypothesis more strongly. The DOPS study population in recently menopausal women with similar characteristics to women in observational studies from which the cardioprotective hypothesis was developed. Women in DOPS were on average 50 years and 7 months past menopause when randomized to MHT or no MHT. CVD was reduced by 52% after 10 years of MHT compared with no MHT, and reduced by 39% after 16 years of total follow-up. All-cause mortality was reduced by 43% after 10 years of MHT and by 34% after 16 years of follow-up. Observational studies, some RCT meta-analysis of women initiating MHT less than 60 years and or less than 10 years since menopause, and DOPS show similar reductions of CHD. Thus, while the effect of MHT on CHD overall is null or harmful in the large RCTs like WHI, there are studies that support the beneficial effects of MHT according to time of initiation of MHT relative to health, relative to age, or to menopause. Many now agree that age or time since menopause influences the risk-benefit ratio associated with MHT with respect to CHD. Then, the Boardman 2015 meta-analysis of oral MHT in postmenopausal women performed a subgroup analysis in those who started MHT less than 10 years since menopause. Results included a lower risk of CHD and lower overall mortality. However, the quality of the evidence was rated as weak to moderate, principally because DOPS, which had been widely circulated as being methodologically flawed. When DOPS was removed from the trials in the meta-analysis, the results became statistically insignificant. It was in fact the DOPS that motivated the Cochrane group to review MHT for CHD in postmenopausal women just 2 years after the previous review of 2013. And they found that in the trial population as a whole, there is no evidence that hormone therapy has a role in either the prevention or treatment of cardiovascular disease. There was no strong evidence that treatment with hormone therapy had an effect on overall death rates. There was also no strong evidence that menopausal hormonal therapy had a favorable effect on cardiovascular disease-related death, non-fatal MI, angina, or vascularization. In the analysis of death, there was no strong evidence of difference in survival until 10 years after treatment, where there was a small survival benefit in the hormone therapy group noted. However, a significant trend for reduction in coronary heart disease risk for women who initiated hormone therapy within 10 years of menopause was observed. Subgroup analysis of time of treatment commencement in relation to the menopause found a benefit in overall survival in coronary heart disease in the hormone therapy group. In those who started MHT less than 10 years after menopause or before the age of 60. This was similar to the trend of coronary heart disease events in WHI2. These findings of possible CV benefits and no harm in younger women given MHT early since menopause, including findings in the DOPS, did not cause the USPSTF, the NAMS, the Endocrine Society, the AACE, the Society of Obstetrics and Gynecology of Canada, the ACOG, the AHA, nor the Cochrane Group to change the recommendation against the use of hormone for primary prevention of CHD. These organizations still say that MHT is indicated only for management of menopausal symptoms, not for primary prevention, and that women who are recently menopausal, and that for women who are recently menopausal, the improvement in vasomotor symptoms must still be weighed against other potential risks of treatment. Why? For one, many of the studies being cited in support of the use of MHT, even when qualified by the timing hypothesis, are flawed. An example is the DOPS, which recorded only 49 cardiovascular events at 10 years and 86 events at 16 years. Trials with small numbers of outcome events can result in extreme findings, which are often attenuated or even reversed in larger trials. Importantly, DOPS was an open-label trial, and participants knew whether they were receiving hormone therapy, which may have resulted in differential use of healthcare services or clinician diagnostic bias for certain outcomes. The DOPS investigators interpret their findings as clear support of the timing hypothesis, but the limitations of the trial make it fall short of proof. Definitive studies using hard endpoints in assessing the primary prevention of CHD with MHT and taking the timing hypothesis into consideration would likely need a very large study population, estimated at 30,000, with 10 to 15 years of follow-up. To date, these trials have not been conducted. Here is what the USPSTF said about hormone therapy for the primary prevention of chronic conditions. They recommend against the use of combined estrogen and progestin for the primary prevention of chronic conditions in postmenopausal women, and recommend against the use of estrogen alone for the primary prevention of chronic conditions in women women who have had a hysterectomy. And here are the recommendations of others. The NAMS, that treatment should be individualized to balance the potential health benefits and risks of each woman. The Endocrine Society said mostly the same thing. And both societies know that hormonal therapy is not approved by the US FDA for the primary or secondary prevention of CVD. The Society of Obstetricians and Gynecologists of Canada say that MHT is not indicated for the primary or secondary prevention of CVD, and neither does the American College of Obstetrics and Gynecologists at the present time. At the moment, this group of experts, OBGYN societies and regulatory agencies, believe that there is just not sufficient evidence to indicate the use of MHT other than for menopausal symptoms. Tomorrow may be another story. But for now, we continue to focus our clinical recommendations of lifestyle intervention, weight management, lipid-lowering medications, control of hypertension, and treatment of diabetes in the prevention of CVD, even during the critical window of midlife of female patients. There is critical need for individualized counseling on the indications and benefits of HT as a treatment option for menopausal women. This is a significant clinical consideration because cardiovascular disease is commonly diagnosed around the time that patients are seeking medical treatment. In summary, this is how I would use menopausal hormonal therapy in healthy postmenopausal women. And as you can see, if there are no symptoms of menopause, whether the patient is at high risk, moderate risk, or low risk of CHD, I would not advise MHT as indicated in the treatment of in the prevention of CHD in women who do not have any other indications for MHT. If the postmenopausal woman has symptoms of menopause and the woman is at high risk of CHD, I would not recommend menopausal hormonal therapy. If the patient, however, is at moderate risk, it is something that you might want to discuss with the patient. If the patient has low risk of CHD, then I might use also hormonal therapy. Thank you very much.
Thank you, Dr. Cabral. That's a beautiful, elegant discussion. You may want to take the seat on the sofa. And so now we come to the rebuttal. So we can call on Dr. Tan to give his 5 minutes of rebuttal.
Hi. I am absolutely at a loss how to explain how two people of proven intelligence can look at the same thing and have completely different conclusions.
It's like looking at a painting, sir.
Yeah. Now, I'd like to say this. I like the first slide today.
Go ahead, please.
Much has been said about the DUMPS and how poor the DUMPS study was and how it has derail the statistical analysis of why MHT is preventive or not preventive of coronary heart disease. I'd like to go back to WHI. WHI's biggest, so far, the largest, most expensive RCT ever done in the history of women's health. Costs about $1 billion as of now. And that's why when Dr. Delfin said, we need a study to really test WHI. We need 30,000 women. We need about 10, 15 years of doing that. That will never happen. No company, WHI is not sponsored by any company, it's sponsored by the National Institute of Health. This is the Department of Health, USA. Trump. Right. But nobody, not even government, will be able to support that kind of a study. So we will not be able to get this study. Anyway, let me go back to the basic. And that's the WHI, the very first paper that came out that created all the problems that we have now. This is a paper that was published in 2020. And sorry, my mom is not right. Maybe you can use it in Spanish way. Alright. Many of you do not know that before the WHI paper was published in July 16, 17, 2022 in JAMA, there was a press conference.
2002, sir.
2022, but July 16. Right. Before that paper was published in JAMA, July 16, 2020, 1 week before that, there was a press conference in National Press Club in Washington, D.C. Investigators announced the whole world, the whole press, why the WHI study was stopped 5.2 years, the CE plus MPAR. And during this press conference, there was a press release, and I'm going to give you excerpts in the press release about cardiovascular disease. Right. This is from Jack Russo, who authored the first paper, and is the director of the WHI. And he said in the press conference, this is amazing press conference. The findings show a 23% increase in total cardiovascular risk, and a 29% increase in heart attack. This is what we're talking about, 29% increase in heart attacks. Without explaining to the reader, to the press, to all the world, that this is not 29 out of 100.
I'll see you. Bye-bye.
Because people will take 29%, that's 29 out of 100, it's too much. This is 29% higher risk than the risk in those who are using placebo. Because whether you take HIV or not, you can have cardiovascular disease, you can have breast cancer. Now, what is the risk in the non-user? And in the user, there's a 29% increase in the risk that the non-users have. So it's not 29, it's 29% of the risk or the background risk in the general population of the placebo users. Anyway, let me show you something. Alright. Let's not talk about the breast. I'm going back to the first paper. This is July 17, 2020. I'm going to show you this. In this paper, this is exactly from the paper. There were two calculations of the relative risk for cardiovascular disease. First one is the nominal 95% confidence interval. Second one is adjusted. Total 1.99. So 29% increase in risk above the placebo users. The nominal 95% confidence interval is 102 to 129. That is statistically significant. So there's a 29% statistically significant increase in the risk of cardiovascular disease in women using CEA. In the same paper, they adjusted the 95% confidence interval, and it came out 1.29, but where do you see the 95% confidence interval? It was 1. So in the same paper, they rejected nominal W, not 95%, but because they adjusted it, and I think they adjusted 95% CI would be much more valid than the nominal one. But this was never mentioned in the press conference. Right. Now, Many of you do not know that about 1 year later, another paper came out. Estrogen plus progestin, risk of coronary disease, this time New England Journal of Medicine. This is the same study that were published in 2022 with one difference. The difference is diagnosis.
Sir, it's 2002.
2000, right? The main difference is in the 2022 paper, the diagnosis of cardiovascular disease was done by the different centers. In this paper, same data, the diagnosis of cardiovascular disease in all the centers was adjudicated by central committee. And so I call this the final results. And this is how it came out. Nominal 1.24, 95% CI, touch 1, statistically not significant. Adjusted 1.24, not significant. Where is cardiovascular risk? It's none. So we criticize the docs, but do we have the right to criticize the well cycle? Right. Then there's another paper. This is the CE alone arm. And this was issued in 2004, right? After 6-8 years of study. And in both nominal and adjusted 95% CI, there was a decrease, but they were not statistically significant. So what I'm saying is, people are afraid of the increased risk of cardiovascular disease if you give HRT in women over 60, and they call it substantial increase, 99% increase in risk. There's nothing there. There was none effect. And that is the reason why I'm confused. Why do we blame doubts? We don't blame the child. That's my problem.
Thank you, Dr. Tan. Can we hear from Dr. Akabra? This is quite riveting. Look at the audience, it's so quiet. Nobody's going in and out of the room to go shopping. Okay, Dr. Akabra.
Yeah, well, first, I'm not surprised that two people can look at one thing and come out with different opinions about it. And it's the same thing with laws. There is a matter of interpretation even with laws. So what happens is one expert and another expert can look at the same set of data and come out with different conclusions. In this case, it's really perhaps the number of people who agree with one conclusion versus another conclusion that comes out in our decisions in clinical practice. So I am sure that many experts will have different opinions about things like this. And it doesn't make one or the other wrong. On their interpretation is their own interpretation. And as Dr. Tan said, initially in his slide, an opinion. So that is the opinion of Dr. Tan, and this is my opinion. It doesn't really count as far as your decision making is concerned until you weigh it yourself and come to a decision yourself.
Thank you, Dr. Akabra. So we don't have to go far. In America, they have alternative facts, alternative truths. So the floor is now open. Anybody would like to ask any question, please? Sorry, I wanted to say a few more things. Oh, I'm so sorry. Go ahead now.
Okay. Why don't you sit down?
Sir?
I was flashing any more slides. Okay. For the moment, as Dr. Tan showed, there are different interpretations of the risks of coronary heart disease in women. But I think at present we can all, or mostly all of us will agree that estrogen is not harmful to and may not increase coronary heart disease. The question is whether it actually benefits them. I don't think that the question of whether MHT is harmful to CHD now is the question, no. It is whether it actually benefits CHD. And then the second is, he is right that when he shows this risks of heart disease, they are all relative risks. But if you look at the absolute attributable risk of estrogen on CHD, for example, even breast cancer, they are really small. They're counted by like 5 or 6 in 10,000 women years. So it's really quite small. So really, this kind of thing becomes an issue between each individual patient and doctor, that they make a decision knowing that these are the risks and these are the benefits.
Thank you, Dr. Anybody would like to bring up a question? So quiet. No, I'm curious, Dr. Dr. Tan, yes.
Look at this. Look, this is the final argument of why I am right. These are the indications approved by the FDA. All the society was mentioned earlier as not approving the use of MHT for primary prevention, based their argument on the fact that WHO said, they said that there is no benefit, but based on the fact the FDA itself has not approved MHT for the prevention of coronary disease. And these are the indications as of 2017, approved indications by FDA. We know all of this based on the symptoms, pscm, POI, and prevention of osteoporosis. If it can be approved for prevention of osteoporosis, why can't it be approved for the prevention of coronary disease in women below 60? Not in women above 60. What's the difference? If you give it to the bones, aren't you giving it also to the heart?
Dr. Arfaka, see if this is never ending.
Well, that's the reason why I premised my position as the use of MHT for the sole indication of prevention of coronary heart disease. Because if there are other indications for MHT, by all means use it, and you can confidently tell your patients that this is not going to harm your heart, and there may or may not be some benefit from it. But if the person is asymptomatic, does not need MHT for anything else, I'm not going to start MHT to prevent cardiovascular disease in the population.
Thank you, Dr. So we're not going to get our cardiologists taking the MHT away from our patients. Last statements, or we're running out of time.
This is my last statement. I agree with Dr. Arfaka. It's not given for women without any problem in the perimenopause and menopause. But this is the rub.
This is the rub, okay.
My obstacle in delivering that. Give me a woman in perimenopause and menopause who has no problem, who has no symptoms. Right. She has no symptoms, no asthmatic symptoms. She has no GSM, right? She has no worries, she has no mood changes, she has no reduction in bone mass. She's not depressed. Have you ever seen a woman like that?
A woman that doesn't come to your clinic.
Well, one reason why she may not have symptoms because she's not complaining. Or because the symptoms are considered normal or natural at this age. Just because she's not complaining doesn't mean she has no symptoms. If a tree falls in the forest and nobody hears it, does it mean it's not falling?
Okay, sir, I'm going to have to cut you here now. Can I just have a show of hands? Who will give MHT for primary prevention of coronary disease? Raise your hands. maybe Dr. Dan, you can have some supporters. Thank you very much. And we move on. Thank you very much. That's a wonderful, wonderful debate of great minds. So I'd like to call in our next speaker, because I'm still in charge of this session here. Okay. So that ends our debate. Thank you again to both the experts for that stimulating discussion on a very controversial topic. We will have our last industry sponsored lecture brought to us by Catherine. And the speaker is